Namaskar. Today, I am interested to have clinical discussion on hemiplegia. मित्रो, हेमिप्लेजिया हा खूप कॉमन अशा प्रकारचा आजार आहे आणि त्यामुळं अंडर ग्रॅज्युएट स्टुडंट्स मस्ट नो एव्हरीथिंग अबाउट हेमिप्लेजिया. आता वर्ड जो आहे इज सेल्फ एक्सप्लेनेटरी. हेमी इज हाफ and plegia is paralysis. Half means half of the body. When you talk half of the body, naturally it includes upper limb, lower limb, and half of the face. Very simple. And therefore, hemiplegia is a condition where there is a paralysis of half of the body. I told you in my last clinic that if there is a incomplete paralysis, then we call it as hemiparesis. And if it is complete paralysis, then you call it as plegia. I am repeating few words for the interest of the students that if you get paralysis of both upper and lower limb, we call it as quadriplegia. If you get only one upper limb, we call it as monoplegia. And when you get half of the body, it is called as hemiplegia. If you get only one lower limb, most of the students don't know this, is called as crural plagia, Crural. But generally, what you get is a total half of the body. Now, when we know what is hemiplegia, suppose patient has a right-sided hemiplegia, then in that case, the speech center is on the left side. And therefore, even on telephone, you can ask, if somebody tells you that there he a patient develop अर्धांगवायू झालाय तर आपण लगेच म्हणतो की बोलायला त्रास होतो का. If the patient has difficulty in speaking and he is not able to speak, aphasia, therefore the speech center is on opposite side, and especially right-sided paralysis is always associated with difficulty in speech. Now, once we know the definition of hemiplegia and difference between hemiparesis and hemiplegia, we come to etiology or causes of hemiplegia. Now, Mitro, commonest cause is atherosclerosis, and second cause is inflammation of a vessel called as vasculitis. The remaining causes, fibromuscular dysplasia and remaining rupture or dissecting of the aorta, need not be remembered by the students. The students should remember two important causes. One is vasculitis, because vessel can be involved in a young man because of tuberculosis. A 20 years fellow gets hemiplegia because of tuberculous vasculitis. And therefore, remember atherosclerosis and vasculitis. Now, when I say that, when you say atherosclerosis, what happens? All of you must have learned in second MBBS pathology that this process of atheroma, lipids being deposited, atheromatous plaque, which occurs either in coronary artery or it can affect middle cerebral artery. Now, if the plaque is there, what happens is that this plaque ruptures. Once it ruptures, the platelets come out, and all platelets together, when they come together, we call it as a thrombus. And therefore, the middle cerebral artery, which is commonly involved, get blocked. If it gets blocked, naturally, blood supply to the part of the brain obviously either is reduced or totally lost, giving rise to a paralytic event. Same story can occur in carotid artery, where you can get a block and therefore called as atherosclerosis. Friends, this is the most common cause, atherosclerosis, but then there could be some other causes. And other causes are that the blood vessel can rupture, it can break, and if it breaks, we call it as cerebral hemorrhage. A very serious condition. Most of the patients do not recover. Some of them, of course, they are lucky. If properly cared for in intensive care unit, they recover. The third is embolism. Now, in embolism, embolism means that the vessel is normal, but is some foreign particle is coming from outside and entering the circulation in the middle cerebral artery. And therefore, this embolism can be from the heart, mitral stenosis, rheumatic mitral stenosis. And you know that in rheumatic mitral stenosis, the left atrium is enlarged and then you get a thrombus there. Now, if you get a thrombus in the left atrium and patient develops atrial fibrillation, moving this atrial fibrillary, so thrombus, part of the thrombus gets detached, goes into the circulation and obstructs middle cerebral artery. Same situation will be of infective endocarditis, subacute bacterial endocarditis, where there can be a thromboembolism. Now, what is the importance? The importance is that we should know the etiology so that you make a diagnosis. And I always tell to the students that when a diagnosis is made, please remember three major parts of diagnosis: anatomical diagnosis, pathological diagnosis, etiological diagnosis, and these three together become a clinical diagnosis. पोरं काय म्हणतात, sir, what is your diagnosis? Sir, it is hemiplegia. Now, hemiplegia alone is not a diagnosis. But if I say, sir, this is hemiplegia secondary to middle cerebral artery occlusion as a result of hypertension, as a result of diabetes, then it becomes a complete diagnosis where you get anatomy, middle cerebral artery, pathology, atherosclerosis, etiology, diabetes mellitus, and clinical diagnosis becomes of all these three together. Please remember this not only in nervous system, for any system, not only in medicine, but even in surgery, gynec, wherever you are talking about a diagnosis, please remember as far as possible, there should be anatomical diagnosis, pathological diagnosis, and etiological diagnosis. Now, when I told you embolism and this cerebral hemorrhage आणि थ्रॉम्बोसिस, मग आता हिस्ट्रीमध्ये कसं ओळखावं? हिस्ट्रीमध्ये एक माणूस आहे, मी नेहमी सांगतो, विच आय हॅव सीन सो मेनी केसेस इन माय लाईफ. ही इज अ बिझनेसमॅन. आणि बिझनेसमॅन असल्यामुळे काय होतं, सकाळी उठतो, दुकानावर जातो, गादीवर बसतो आणि सारखा बिझनेसमध्ये फोन करतो, आया और दिया. मग जर फोन चालू नसेल तर सिगरेट घेतो आणि सिगरेट प्यायला सुरुवात करतो. घरी गेल्यानंतर चांगलं तूप नेहमी खाण्यामध्ये येतं, फॅट चांगण्यात येते, त्यामुळं ह्याचं वजन वाढलेलं असतं. वजन वाढलं आणि स्मोकिंग, वजन वाढलं, वडिलांना डायबिटीस, she may develop because of overweight diabetes mellitus. And therefore, in thrombosis, remember that there are certain risk factors. The risk factors are diabetes, hypertension, smoking, overweight, sedentary, and in females, oral contraceptives. Oral contraceptives lead to hyperviscosity, and therefore the lady may get hemiplegia. Not very common. So this businessman is overweight, 95 kilo weight, smokes about 20 cigarettes per day, is busy in his continuously working and sitting on gaddi, so no exercise, and goes back at about 8 o'clock, sleeps well. And in the morning, the wife brings a cup of tea to him. And when the cup of tea is being given, he is not able to speak. She says, काय झालं तुम्हाला, तुम्ही बोलत का नाही? आणि then with his left hand, she shows that his right hand is not able to work. Right-sided hemiplegia with aphasia. This is an insidious story called as cerebral thrombosis. Now, when we talk of hemorrhage or embolism, it is a sudden onset. It is sudden onset and progressively goes very fast. If I have to tell you the clinical scenario, as I told you of cerebral thrombosis, I will tell you of hemorrhage. A young boy, 22, 24 years, passes engineer, does not get admission by 2 marks in medical, and therefore he has to go to engineering. He passes engineering college, and because he is basically intelligent, hardly 2 marks difference, he gets a engineering degree in merit. The parents are very happy, and he joined as a junior engineer or senior engineer in a IT industry. Now, when he is working, he is paid a lot, which is called as 10 lakhs, 12 lakhs package. And therefore, when large amount of money is being given, the responsibility also increases. And therefore, he is told that this work you must do in 24 hours this much. He is not able to do that, whatever are the reasons. And therefore, he develops stress. If he develops stress, there is a sympathetic overactivity. Blood pressure is elevated. And diastolic as well as systolic in a young man. And the fellow develops 200 systolic and 140 diastolic. Normal blood pressure is 120/80. He develops 200/120 blood pressure. Suddenly develops giddiness and vertigo. Vertigo म्हणजे सगळं फिरणं, गोल फिरतं जग. Severe headache, develops convulsions, becomes unconscious and has hemiplegia. Sudden onset. This is classical story of cerebral embolism. I will repeat. In hypertensive hemorrhage, the story is that the patient complains of excruciating headache, vertigo, moving around, convulsions, and develops a neurologic deficit in the form of weakness in one half of the body. Diagnosis is cerebral hemorrhage. Now let us talk the story of embolism. A patient is again a 30 years young man, a lady, 30 years young lady, and develops breathlessness, goes to a doctor. Doctor examines her and says that तुमच्या हृदयाची एक झडप खराब झालेली आहे. That is mitral stenosis. And if she develops mitral stenosis, complication of mitral stenosis is atrial fibrillation. मग एट्रिया फिब्रिलर झाली की थ्रॉम्बस होतो तिथं लेफ्ट एट्रियम मध्ये. Left atrium is enlarged because of narrowing of mitral valve. And then this thrombus, because there is a movement of fibrillation in the atrium, the clot gets dislodged and goes to mid cerebral artery and sudden development of injury. 10 वाजेपर्यंत बाई चांगली आणि 10:15 suddenly she develops paralysis in the half of the body, which is called as embolism. Now, when I talk that, there are certain terms in cerebrovascular disease which undergraduate students should know. And those terms are, one is TIA, second is lacunar infarct, and third is a patient, lacunar infarct is TIA and RIND. आता TIA म्हणजे काय? TI चा लॉंग फॉर्म इज ट्रान्सिएंट इस्केमिक अटॅक. म्हणजे काय होतं पेशंट? नाव रिस्क फॅक्टर असणारच, हाय ब्लड प्रेशर, डायबिटीस, ओव्हरवेट, आणि सगळे नसले तरी 1-2 असतात. हायपरटेन्शन, डायबिटीस जनरली असतात. अराउंड 50-60 वर्षाचा माणूस, 45-50 वर्षाचा माणूस. आणि मग काय होतं की हा सकाळी काम करतो, कामाला जातो. कामाला जाता जाता एकदम त्याच्या डोळ्याला, एका डोळ्यामध्ये काहीही दिसत नाही. मानोऑक्युलर ब्लाइंडनेस. आणि मग एका डोळ्यामध्ये एकदमच अंधार पडतो, दिसत नाही, आणि काही क्षणात नॉर्मल होतो. मग थोडं झालं की 11 वाजता ऑफिसला जातो, आणि 11 वाजता गेले की त्याला असं वाटतं की आपल्या हातातली ताकद कमी व्हायली, जाणीव होते. ती कसं? काही मिनिट आणि काही मिनिटांना तो एकदम अगेन चांगला होतो. किंवा पॅरालिसिस होतं आणि 24 तासाच्या आत completely रिकवर होतं. That is called as transient ischemic attack. Transient ischemic attack is a patient having a neurological deficit which recovers within 24 hours is called as transient ischemic attack. Second is RIND. RIND is a long form आहे बघा, की रिव्हर्सिबल इस्केमिक न्यूरोलॉजिक डेफिसिट. नाव व्हॉट इज द डिफरन्स? TIA मध्ये आणि RIND मध्ये काय फरक आहे? TIA मध्ये मी सांगितल्याप्रमाणे 24 तासात पेशंट एकदम नॉर्मल होतो. पण RIND मध्ये त्याला 8 दिवस लागतात, कोणी म्हणतात 10 दिवस लागतात RINDच्या डेफिनेशन मध्ये. पण जनरली 8 दिवसामध्ये पॅरालिसिस राहतं आणि तो रिकवर होतो. अँड दॅट इज RIND. अंडरग्रॅज्युएटला ही टर्म्स विचारतात. आणि तिसरं लॅक्युनर इन्फार्क्ट, व्हेरी इम्पॉर्टंट. लॅक्युनर म्हणजे काय, की एकदम डीप इनसाइड द ब्रेन द व्हेसल्स गेट ब्लॉक, मायक्रोएम्बोल आहे. अँड वेन दीज पुचर्ड म्हणतात त्याला, अॅन्युरिझम, बेरी अॅन्युरिझम ऑफ दी पुचर्ड, तर त्या फुटतात म्हणा, बारीक ज्या असतात इन द डीप स्ट्रक्चर ऑफ दी ब्रेन, they get blocked, and that is called as lacunar infarct. Lacunar infarct generally साध्या CT स्कॅन मध्ये दिसत नाही, पण MRI मध्ये यू कॅन क्लासिकली सी द लॅक्युनर इन्फार्क्ट. बर नाही. आणि त्यामुळं लॅक्युनर इन्फार्क्ट is again asked in examination. So lacunar infarct is that the small vessels inside the deep part of the brain are occluded, or there is a rupture of a small vessels, giving rise to certain clinical signs. आणि त्यामुळं जर विद्यार्थी चांगलं करत असेल परीक्षेमध्ये, तर त्याला विचारण्यात येतं की व्हॉट आर दी क्लिनिकल प्रेझेंटेशन्स of a lacunar infarct. Now, clinical presentations are motor hemiplegia, paralysis of half of the motor system affected, sensory system is affected. And I told you earlier that if there is a damage to bilateral pyramidal tract, what is it called as? It is called as pseudobulbar palsy. And therefore, that is the third manifestation of transient lacunar infarct, and fourth is dementia. So these are 3 to 4 presentations of the lacunar infarct. Now, after knowing these 2-3 terms, we come back to examination of a patient after knowing the causes of hemiplegia. आता पेशंट झोपलेला आहे आणि आपण पेशंटकडे पाहतो किंवा पेशंट आपल्या कन्सल्टिंग मध्ये येतोय, तर मग आपण कसं ओळखतो that he has hemiplegia? Friends, remember that his half of the face is affected and therefore his nasolabial fold is flattened up. And therefore, when you look at him, you find that his nasolabial fold is flattened and his upper extremity is paralyzed. What happens? You find that there is an adduction. I'm going to show you in a gate. There is an adduction of the upper limb. There is a extension, flexion of the elbow joint, flexion of the wrist joint, and extension of the finger. And in lower limb, extension of a limb, extension of hip, extension of knee, and eversion of the foot, which I will be showing you in a gait of hemiplegia. So when he is coming down, you can see this picture and say that the patient has hemiplegia. Patient lies down. Naturally, history मध्ये I already discussed in detail what points in history you should ask. So he is lying down and I start examining. What I do? The first thing I do is to see the pulse. And you know that in every pathy, whether it is naturopathy, whether it is allopathy, or whether it is homeopathy, or Ayurveda, or as I believe in, which pathy you are following is not important. most important is sympathy. And therefore, when I sympathetically try to examine this patient, I look for the pulse. आणि पल्समध्ये मी काय पाहणार? पल्समध्ये मी पाहतो की ही रेग्युलर पल्स आहे का इरेग्युलर पल्स आहे. आणि इरेग्युलर वाटली तर मग इज इट रेग्युलरली इरेग्युलर ऑर इट इज इरेग्युलरली इरेग्युलर. आणि तुम्हाला सारखं सांगण्यात येतं टीचर्सतर्फे दॅट इन एट्रियल फिब्रिलेशन यू गेट irregularly irregular pulse. So when I see pulse, I find that pulse is irregularly irregular. मग मी खालच्या वेसल्स पाहतो. कोणत्या? पोस्टेरियर टिबियल, anterior tibial artery, dorsalis pedis, and see the pulsations on both sides if they are equal. So I am finding that the patient has normal pulse rate, there is no irregularity, peripheral pulses are normal. The man is about 50-55 years of age, hypertensive, non-diabetic patient. सांगतो तो साखरेची बिमारी आहे आणि बीपीच्या गोळ्या घेतो मधून. And therefore, when I examine this particular patient, I take blood pressure. Normal blood pressure is 120/80, and I examine this fellow and I find that is 180/110 or 120, confirming that he has hypertension. So next step will be to take the blood pressure. After that, I go for the neck, examination of the neck. I am talking about general examination. I am talking about general examination in a patient of hemiplegia. General examination with the pulse rate, peripheral pulses, blood pressure, and then I go to the neck. In neck, I look for neck stiffness. It means patient is not able to put his chin over the front of the chest and he gets a pain in the back. It means there is a neck stiffness. Severe neck stiffness is very common in cerebral hemorrhage, in meningovasculitis, and therefore the examination of hemiplegia is not complete unless you look for neck stiffness. Second dictum of mine is that the examination of a patient of hemiplegia is not complete unless you put your hand over the carotid artery, pulsations of the carotid artery, and you must see whether the carotid arteries are equal on both sides. Why do I look for? I look for because there can be a block in the carotid artery. And if there is a block in the carotid artery, blood supply becomes less to middle cerebral artery and patient develops hemiplegia. On the opposite side, remember, contralateral hemiplegia, if there is a diminished carotid artery on one side. And then I try to put my stethoscope over that and I find there is a systolic sound. A systolic murmur heard over a vessel is called as bruit. What is bruit? Always ask in examination. So bruit is a systolic murmur heard over an artery. So I put a stethoscope and I get a you get a systolic sound like that, systolic murmur. It means definitely this carotid artery is blocked. If it is left-sided artery block, patient will develop right-sided hemiplegia. And therefore, general examination, pulse rate, irregularity of pulse, peripheral pulses, blood pressure, palpation of carotid artery. Then I go to examination, systemic examination. आणि सिस्टमिक एक्झामिनेशन मध्ये आधी मी दुसऱ्या सिस्टम घेतो अँड देन आय विल कम टू नर्वस सिस्टम. तर दुसऱ्या सिस्टम मध्ये मी काय पाहिजे? मी पाहणार की जर नेक स्टिफनेस पेशंटला असेल तर मग कर्निक साईन आहे का? कर्निक साईन मध्ये काय करतो आपण की पाय हा फ्लेक्स करायचा नी आणि द नी शुड टच दी चेस्ट. सो फ्लेक्स दी लेग, flexion of the knee, and knee should be flexed to hip flexion. आणि मग हा पाय एक्सटेंड करायचा. हा एक्सटेंड केला की पेशंट कंप्लेन्स ऑफ pain in the back, and there is a spasm of the hamstring muscle, and therefore we say that Kernick sign is positive. If you get Kernick's positive and Hicks stiffness, it indicates that there is a meningeal involvement, and this meningeal involvement could be because of a cerebral or meningoencephalitis. सो जनरल एक्झामिनेशनमध्ये त्या दोन पॉईंट्स पाहिजे आणि मग आपण कार्डिओव्हास्क्युलर सिस्टमकडे जाऊ आणि कार्डिओव्हास्क्युलर सिस्टमकडे गेलं की आय पुट माय स्टेथोस्कोप ओवर द मायट्रल एरिया अँड व्हॉट डू आय गेट? I get a loud first sound, a mid-diastolic murmur, pre-systolic accentuation, and opening snap. I will repeat. I get a mid-diastolic murmur. You may get opening snap. You may not get M1 loud. That I will talk a little later. But you will definitely get a mid-diastolic murmur with a loud first sound. आणि जर पेशंटला एट्रियल फिब्रिलर असेल mitral stenosis पेशंटला तर pulse will be regular and pre-systolic murmur will be absent. In normal mitral stenosis, which is a very severe mitral stenosis, you get four signs: mid-diastolic murmur, loud first sound, opening snap, and pre-systolic accentuation. But if there is atrial fibrillation, you may not get pre-systolic accentuation, but you will get a mid-diastolic murmur, which will tell you that this patient has a mitral stenosis. So mitral stenosis is an atrial fibrillation, and therefore what will happen? That thrombus get detached, as I told you, goes to middle cerebral artery, and patient develops hemiplegia. So we know then what is the etiology of hemiplegia. मग आम्ही काय म्हणणार? Diagnosis, anatomical, pathological, etiological. Patient has a right-sided hemiplegia secondary to embolism as a result of organic mitral stenosis with atrial fibrillation. So distinction marks if the student tells that anatomy, pathology and etiology. मग आम्ही कार्डिओव्हास्क्युलर सिस्टम तपासणार या पेशंटची, where you may get emboli. मग मी इन्फेक्टिव्ह एंडोकार्डायटिस आहे का पेशंटला हे पाहणार. इन्फेक्टिव्ह एंडोकार्डायटिस करता मी नेहमी विद्यार्थ्यांना सांगतो की देर इज अ रूल ऑफ 5P. 5P मध्ये पायरेक्सिया, पॅलर, palpable spleen, positive culture, palpable nodes. That we will talk a little later. But remember rule of 5P in bacterial endocarditis. त्यामुळे anemic patient आहे, spleen palpable आहे, pyrexia आहे, fever आहे. Naturally you suspect that this could be infective endocarditis giving rise to embolism and giving rise to hemiplegia. हे सिस्टमिक एक्झामिनेशन झाल्यानंतर मी नर्वस सिस्टम तपासतो. नर्वस सिस्टम मध्ये सिस्टमिक नर्वस सिस्टम मध्ये मोटर सिस्टम, सेन्सरी सिस्टम, क्रेनियल नर्व्स, ब्लॅडर अँड कॉन्शियसनेस, हे 5 गोष्टी मी पाहणार. आणि मग मी सुरुवातीला पाहणार की पेशंट कॉन्शियस आहे का, अनकॉन्शियस आहे का, सेमी कॉन्शियस. इफ द पेशंट इज अनकॉन्शियस, it can be still both. It can be hemorrhage. Severe cases of cerebral thrombosis can also lead to unconsciousness. So higher function has to be seen. And then motor system. Now, before I talk about motor system, patient is walking to your consulting room. It means it is paresis. It is not plegia. It is hemiparesis. And then therefore, I would naturally talk about gait of the patient, which is called as hemiplegic gait. I will be interested to discuss with you various types of gaits at a later time, and how to diagnose the disease meant on the basis of the gait. So hemiplegic gait is in hemiplegic gait, the elbow is fixed, he is flexed, and adduction. Then the wrist is flexed, and the distal phalanges are extended. Remember, adduction, flexion of the elbow, flexion of the wrist, and extension of the other field. Lower limb मध्ये you find extension of the hip and extension of the neck, extension of the knee, extension of hip, and you get eversion of the foot. And how does he walk? He walks in a I will show you again. Hemiplegic gait, adduction, upper limb, flexion of the elbow, flexion of wrist, extension of the distal finger, extension of the hip and knee, and eversion of the foot. And then he walks in a circumduction fashion. This is called as hemiplegic gait. And therefore, if the patient is walking in our consulting, I would naturally like to look for hemiplegic gait. So I have seen the gait patient is lying down as I told to you. And then I come to motor system. Motor system मध्ये काय होतं? Pyramidal tract can be damaged. And if the pyramidal tract are damaged, I have told you repeatedly that you will get a upper motor neuron type of lesion. And therefore, I will again repeat that what will happen? That I examine his right upper limb, lower limb, and I find that there is no wasting. I don't expect. I expect wasting in a lower motor neuron lesion. But in upper motor also I may get wasting if the paralysis remains for a long time, which is designated and called as disused atrophy. त्यामुळे वेस्टिंग नसते. Then we come to tone. There is hypertonia, which is called as class 9 spasticity, which I already told. Right? So tone is increased. There is no wasting. And then we come to power. Power मध्ये मी तुम्हाला मोटर सिस्टम बद्दल डिटेल नंतर सांगणार आहे. त्यावेळेस मी ग्रेड्स ऑफ पॉवर्स तुम्हाला सांगेल. And I am going to show you how all muscles could be tested in reference to their power, grades of power mentioned by ICMR. But power is less. It is not absent. If it is absent, it is hemiplegia. So less power or no power. Coordination cannot be tested because of less of power, which I already told you. Okay. So involuntary movement may or may not be present. And then we come to plantar reflex or Babinski's sign. Pathognomonic sign of pyramidal damage is extensor plantar, and therefore you will get extensor of plantar. Friends, one more most important point you should remember, that when there is a acute insult called as hemiplegia, you may not get deep reflexes exaggerated. It takes time. It takes time, remember, and that is called as cerebral shock. I talked to you about spinal shock. So cerebral shock मध्ये upper limb मधले biceps, triceps, knee jerk, ankle jerk, they are absent. They are not exaggerated. They would be exaggerated after some time. If the paralysis remains for 8 days, 10 days, then slowly you get all those signs. पण इनिशियली तुम्हाला एक्झॅजरेटेड रिफ्लेक्शन मिळत नाहीत. ते त्याचं कारण म्हणजे सेरेब्रल शॉक. मग कसं कळायचं की पिरामिडल डॅमेज झाले म्हणून? द बेस्ट वे इज टू लुक फॉर प्लांटर एक्सप्रेशन. So deep reflexes are absent, but plantar is extensor, bilateral, unilateral extensor. Bilateral extensor will come in paraplegia. So you will get one side, the plantar is extensor, even if the deep reflexes are absent. This is about motor system, very simple. Then I come to sensory system. Depending upon the ischemia in the brain and various areas of the brain are affected, you may get involvement of sensory system in reference to pain, touch. Pain and touch mainly will be affected That is in reference to sensory system. And therefore, motor system and sensory system. Then I come to cranial nerve. A student would not be able to pass if he tells that which cranial nerve is not affected in a hemiplegia. Which cranial nerve is always affected, and that is facial nerve. So in facial nerve मध्ये काय होईल? How will you know that facial nerve is affected? महत्वाचं म्हणजे flattening of the nasolabial fold, and only lower part is affected. Ask him to share teeth and you find that lower half of the face is affected. If lower half face is affected, it means it is upper motor neuron type of facial palsy. If both are affected, ask him to frown. इथे आता आपण फ्राउन केली की तुम्हाला अशा घड्या दिसतात, आणि जर आपण असं केलं आणि एका बाजूला घडी दिसतच नाही, प्लेन आहे, आणि लोअर पार्ट इज अफेक्टेड, इट मीन्स बोथ अपर अँड लोअर पार्ट आर अफेक्टेड. इट इंडिकेट्स लोअर मोटर न्यूरॉन टाइप ऑफ facial palsy called as Bell's palsy. So in hemiplegia, you get an upper motor neuron facial nerve where you get only paralysis of the lower part of the face. Now, I will tell you one more thing, which I will repeat, that when nucleus is affected and lower part of it is affected, it is called as a lower motor neuron. I told you definition of lower motor neuron. It is a part of nervous system starting from anterior horn cell up to muscle and homologous nuclei in the brain. The nucleus of the facial nerve is in pons. आणि hemiplegia मध्ये cerebral cortex is affected, and therefore it is above the nucleus. When the lesion is above nucleus, it is called as supranuclear lesion, and all supranuclear lesions are of pyramidal tract. Am I clear? And therefore pyramidal tract examiner म्हणतो तुम्हाला की तुम्हाला काय वाटतं की लोअर मोटर न्यूरॉन फेशियल इज pyramidal tract. मग आपण उत्तर द्यायचं की pyramidal hemiplegiaमध्ये cerebral cortex is affected while the nucleus of the facial nerve is in pons, and when the lesion is above the nucleus, it is called as supranuclear paralysis, and all supranuclear paralysis will have the upper motor neuron lesion. Am I clear? And therefore, on clinical examination, I find upper motor neuron facial, motor system affected, sensory may or may not be affected, all deep reflexes are absent on one side and plantar extensor. So with this, I come to conclusion. I make a clinical diagnosis that this patient has a right-sided hemiparesis with aphasia secondary to middle cerebral artery thrombosis as a result of hypertension and diabetes. हे झालं पूर्ण anatomy, pathology and etiology. मग patient येतो, how do I confirm? It is necessary to confirm whether it is thrombosis or whether it is hemorrhage, because treatment will vary. Am I clear to you? One is a boon, other is a curse, and therefore you must know how to confirm that whether it is cerebral thrombosis or whether it is hemorrhage. So best nowadays either they do CT scan or MRI, and CT scan केलं की तुम्हाला hemorrhage दिसतो. If you see the hemorrhage, it means diagnosis is cerebral hemorrhage giving rise to hemiplegia. तिथे तुम्हाला infarction दिसलं, hypoechoic areas, and then you say that this is a thrombosis. You get lacunes, meaning thereby that it is a lacunar infarct. Am I clear to you? So you may get evidence of thrombosis, you may get evidence of lacunar infarct, or you may get evidence of bleeding. MRI or CT scan is a very, very important investigation for confirmation of diagnosis. मग आता आपण डायग्नोसिस हेमिप्लेजियाचं पक्क केलं. कशामुळे झालं हेमिप्लेजिया? थ्रॉम्बोसिस. मग थ्रॉम्बोसिस कशामुळे झालं? हायपरटेन्शन, डायबिटीस. त्यामुळं आपल्याला ब्लड शुगर करावं लागेल, फास्टिंग पोस्ट मील, टू कन्फर्म वेदर पेशंट इज डायबिटिक. हिस्ट्रीमध्ये आपल्याला कळेल whether he is a smoker or not. And to repeat, risk factors for hemiplegia are diabetes, hypertension, smoking, sedentary, overweight, and the thrombosis, oral pills in patients of females. Now, I have done this and I have come to conclusion it is thrombosis removal. You find that there is no thrombosis. I find that MRI, CT scan is normal. मग काय? The third possibility which comes to our mind, especially in a young person. Friends, मित्र, विसरू नका, what are the causes of stroke in a young man? 22 वर्षाचं पोरग, 25 वर्षाचं पोरग, पॅरालिसिस होतं, हेमिप्लेजिया होतं. आपण जनरली 50च्या वर आपण डायबिटीस, हायपरटेन्शन सगळे डिस्कस केलं. पण यंग फेलो ऑफ 25 years comes with hemiplegia. What are the causes of hemiplegia? म्हणजे स्ट्रोक म्हणतात त्याला. And what are the causes of stroke in a young? Causes of stroke in a young आहेत 7, 8, 10 आहेत, पण तुम्ही 4-5 तरी लक्षात ठेवा. जे कॉमन आहे ते आधी मी सांगतो की पेशंटला मायट्रल स्टेनोसिस आहे आणि त्यांनी एम्बॉलिझम होतं, एट्रियल फिब्रिलेशन आय ऑलरेडी टोल्ड, and therefore that is common cause of stroke in a young man. सेकंड, इंजिनियरचं उदाहरण तुम्हाला दिलं, हायपरटेन्सिव्ह सेरेब्रल हेमरेज is the second cause for stroke in a young. Third is berry aneurysm, congenital, which ruptures that can give rise to cerebral hemorrhage. चौथं ब्रेन ट्युमर. आता ब्रेन ट्युमर मध्ये मी सांगतो तुम्हाला with I would like to cite and share an experience that there was a young boy of 24 years, medical officer at primary health center, MBBS, आणि तो आपल्या कामामध्ये गुंग असायचा, ट्युबेक्टमीचे कॅम्प असायचे सगळीकडे. 22 का 23-24 वर्षाचा तो पोरगा असेल, आणि वन फाईन मॉर्निंग he developed convulsions. Suddenly Jacksonian convulsions. When he developed convulsions, he says की गेल्या 15 दिवसापासून माझं डोकं दुखतंय, आणि मग म्हणतो मला मळमळ होतीये. I told you, severe headache, vomiting, blood vision, convulsions are symptoms of raised intracranial tension. And when I find that these are symptoms slowly developing, and one fine morning he develops hemiplegia, think of brain tumor, and brain tumor will be known by the MRI. So that is the next cause of stroke in a young people. Then post epileptic fit, एपिलिप्सी मध्ये जोरात झटके येतात आणि मग हेमिप्लेजिया डेव्हलप होतो, आणि हेमिप्लेजिया डेव्हलप झाला की तो टेम्पररी राहतो. इट इज नॉट कम्प्लीट बट इट रिमेन्स टेम्पररी. देन यू फाइंड दॅट बेरी अॅन्युरिझम बद्दल तुम्हाला ऑलरेडी सांगितलेलं आहे. आणि रेअर डिसीज आहे बघा, ते मल्टिपल स्क्लेरोसिस, जिथे जिथे हा रोग येतो, मल्टिपल स्क्लेरोसिस, where you may develop hemiplegia, severe migraine can give rise to temporary hemiplegia. त्यामुळं जो विद्यार्थी चांगलं करतो, परफॉर्मन्स इज व्हेरी गुड इन हेमिप्लेजिया, तुम्हाला प्लॅन्टर दाखवतो, पॉवर दाखवतो, मग त्याला विचारतो आम्ही की व्हॉट आर द कॉजेस ऑफ ट्रान्झिएंट हेमिप्लेजिया, म्हणजे टेम्पररी. आणि ट्रान्झिएंट हेमिप्लेजिया मध्ये वन इज TIA, transient ischemic attack. Second is migraine, and third is post-epileptic fit after epilepsy. So these are the three causes of temporary hemiplegia, or called as transient hemiplegia. To repeat, TIA, transient ischemic attack, post-epileptic, and migraine. I already told you the presentations of the lacunar infarct, and these are the causes of stroke in a young. If you find that a hemiplegic patient has got a young person, 22-24 years man is admitted. So investigation झालं आपलं पूर्ण, आणि आपण we have come to conclusion, if it is a tumor, naturally hand over it to a surgeon. If it is embolism, then you have to treat the atrial fibrillation which is present there. And then we come to cerebral thrombosis, which is very common. Now, patient is admitted. If he is unconscious, the treatment of an unconscious patient. That is care of bladder, care of back, care of gluteal region, care of food. And these are the ways by which, and care of the bladder, Foley's catheter has to be put. So this is very simple in care of an semi-conscious or unconscious patient. I yesterday also told you that physiotherapy, physiotherapy is the right hand of a physician. And therefore, I have seen patients who had got grade 1 or grade 0 power. And after 3 weeks of physiotherapy, friends, I have seen him walking. And therefore, physiotherapy is extremely essential in a patient of hemiplegia. So, treatment of cause, physiotherapy, and treatment of an unconscious patient are the ways by which we treat patient of hemiplegia. If he is hypertensive and if the blood pressure goes high and he develops paralysis, don't try to bring down the blood pressure precipitously. If it is brought precipitously, again the blood supply becomes less to the brain and patient may develop further increase in paralysis. And therefore, blood pressure monitoring has to be done very well. And now I feel that hemiplegia is a very common disease which is present in our society because of variety of reasons. They don't stop smoking, they don't control or check for diabetes, they do not listen to the family history of diabetes, weight goes on increasing, stress is an inseparable part of life. And therefore, all these things taken together, they don't walk. Where walking is very important to keep your health good. And therefore, if modified risk factors are attended to, then you, in all probability, can prevent or avert cerebrovascular episode. Friends, this is all about, I want to talk about hemiplegia or hemiparesis. Next time, I will be talking to you about the motor system and the various ways all these power of various muscles can be tested. Thank you.